Tonight we are going to talk about the multifunction cardiogram, and I'm going to keep my screen like this so I can see the comments as they come in. It helps me navigate questions and things. Before we get into this, I wanted to share something. We brought in all of this state-of-the-art testing, and a lot of you might be thinking like, I don't really need the testing, I'd just rather have treatment. So one of the things in functional and integrative medicine that I learned really early on is not only do you have to help people get better, you have to show them how you're helping them get better. Because as people improve, they forget where they came from and they just adapt to the new normal. So this is a patient who did a brain gauge and 2 weeks apart, and you can see the tremendous difference. Now this person's doing the MDI, the mitochondrial regen, and some of the other things in our office, thyroid optimization. So you can, this is pretty dramatic improvement for 2 weeks. So first of all, if you did a brain gauge and you were really concerned about your initial findings, don't be, because they can improve. And second of all, this person should be pretty happy with the time and effort they're investing into their health, because this is, when you look at the first one, those people can progress to dementia. When you look at the second one, no one has when they have all green bars. This is actionable data that we have at our fingertips now. So we're going to talk tonight about the multifunction cardiogram. So it is one of our state-of-the-art functional tests that we have brought into the office. This is really thanks to one of our patients who told us about this and said, hey, I want to introduce you to somebody. And they introduced me to the president of the company, and she brought this up and introduced us to it and explained all about it. We looked into it, and it definitely was a great addition to our clinic. So we're going to go over tonight what is an MCG, and that stands for multifunction cardiogram. So an EKG that does a lot of things. We're going to go over how it's performed. What does it tell you? We're going to look at some reports, data supporting its use, who should get one, and then again, an interesting case that I've already had that made it well worth my investment in getting it. So you might be thinking, if you signed up for our testing special, you have one of these included. If you didn't sign up for our testing special, this is something that we can add to your plan. So what is the MCG? The multifunction cardiogram basically is a non-invasive cardiac test that goes beyond the standard EKG. So it's actually looking at the electrical conductivity and the magnetic energy in the heart. It's looking at the magnetic fields in the heart as well as the electrical pulses and the differentials between all of those things. So the EKG is just electrical changes through the heart and through the electrodes of the skin, but the MCG does that over time and takes that another dimension. So why do we need another heart test? If you think about the heart testing that's available, and some of you may have had some of these and others may not have had any. When we look at an EKG, it's about 10% reliable for picking up causes of problems. So it's super easy, it's non-invasive, but it doesn't tell us a lot if it's not an electrical conductivity problem. So there's a lot of things we can pick up with EKG, but certainly not everything. Angiogram is invasive. You're undergoing a procedure. Procedures have complications. It's expensive. It's time consuming. It has to be scheduled or it's emergent. A lot of that. A lot goes into having one of those. The SPECT scan. So this is a nuclear test to look for ischemia in the heart. Again, it's only going to be about a coin toss, sensitive for picking up actionable items. So when we look at the multifunction cardiogram, it has a high negative predictive value. So what does that mean? And I'm actually going to demonstrate that tonight for you. If you come in with chest pain, the first thing I want to know is, are you having a heart issue or not? Is this a heart attack? Is this something actionable with the heart? Or is this your gut? Is this reflux? Or, is it a chest wall problem? So when you have a high negative predictive value, if I order an MCG and the score is less than 4 in the safe zone, it's almost improbable that you could have a significant ischemic event. So it's a layer of certainty upon that. And again, that's where your angiogram, a CT angiogram, people who go to angio only has a 40% sensitivity. So it is a good test, but very few people have actionable disease. So what that means is 62% of people who have an angiogram don't really need it. So we want to minimize that number as much as possible. So how is the MCG performed? You can see it over here on the right. So you just lay on a table, and you can't have any metal in your pockets. The joke is it's worse than TSA. So belts off, shoes off, metal out of pockets, no electronics on the body. So you're going to take out your cell phone, no igniters, lighters, things like that. Those all need to go. And we're going to hook you up. And I call these jumper cables. They really aren't going to shock you. So we put little clips on the ankles and the wrists, and then there's an EKG lead that goes at V5, which is kind of under the breast in the anterior axillary line. So from your armpit, if you draw a straight line down and where that intersects under the breast, that's where that lead is going to go. It's the V5 lead. So we have patients come in and you want to lay down. You want to kind of lay down and hit a steady state. And you're like, well, of course. But a lot of people are driving in through traffic. They're running late. They're hustle and bustle. We've got to have you settle down before we even start the test to get back to baseline or equilibrium. Then we're going to put these leads on. We're going to start the collection. It has to be a very clear EKG signal. So we don't want any interference. If you have electrical devices even around the device, it can't even be plugged in itself while we're doing it. What we found are some of our tables. These are all plug-in tables because they have electrical components. Sometimes even if the table plugs in, that electricity going through that it interferes too much. So we really have to have no electrical current anywhere around this because it's measuring electrical conductivity and again, that magnetism. So you're going to sit there and over time, it's going to take 5 runs of 82 seconds each. So 82 seconds. So you're going to get about 5 minutes worth of telemetry strip data that is going to be archived. So we're going to look at all these strips in the back and make sure they're high quality, no interference, good. We're then going to approve those and send them off to a database. Now, what I found is really fascinating is it's going to go through an AI database. And there's kind of 2 components of that. One is the database is larger than Google. So it's going to compare the EKG leads to millions of other EKGs categorized in different disease states. So it's going to tell us it looks like this or it looks like people who have that. So when we get to the 2 parts of the test, the part that looks at really specific things, it more tells us this looks like patterns consistent with X. It also sends it through an algorithm of different cardiac physiologic equations. This all happens very instantaneously, and it gives us, within a few minutes, it's going to drop a report back to us and give us this information. So we just need that high quality EKG 5 times, 5 runs for 82 seconds each. So during that time, you're not going to be talking, you're not going to be on your cell phone, you're literally eyes closed, chill out, try to just relax and breathe. That's probably the hardest part, is getting people to just relax and breathe. So the 2 parts of the MCG report, the first part is FDA cleared. So this has been studied, it's been validated, it is worth it. This is that high negative predictive value. So what it's going to tell us is which category of ischemia are you in? And you can see here, let me make this a little bit bigger. The N category is true normal. Category A is minimal. B is minor. C is maybe some minor or recovery. D is moderate. E, high dysfunction. F is severe dysfunction. G, extreme. And I think there's an H. And when you are really above E, F, G, you're in trouble. So when we start to see that, we're going to be much more aggressive with our interventions. So this is just going to tell you where do you score. And this letter scoring is based on the severity score and the number of leads. So let's look at this one. So I believe this is a patient that actually was going for a cardiac cath. So here's the report. At the top, you can see there's a clinical score that's an A. So right off the bat, we're saying this is reassuring. So as we look at this, we have 5 samples, 1, 2, 3, 4, 5. So in the complete report, we're going to have all the EKG runs that we're going to inspect for quality control. It'll tell us the date and time they were run. It tells us if the tracing quality was good, fair, or poor, and we don't ever want to include poor in here. And there's a reason for all this information. I'll kind of show you as we get in the more detailed report. So then we're going to look at local versus global ischemia. So local disease, when we think of heart attacks, the body has main arteries that feed the heart muscle. When we get a blockage of one of those, there's a certain real estate that supplies that goes down. That's what creates a STEMI, ST elevation MI. When that specific area has no blood flow, it sends off electrical signals of distress. So when we look at local ischemia, is it tied to a single vessel disease? Versus global ischemia, which is going to be more microvascular. So we've touched on that a little bit with the glycocalyx. More prominent in women, a global issue. This is going to be more your septic, your cardiomyopathies, things like that. Global ischemia, or multivessel disease. And then it's going to give us a severity score for each one of these runs. And that's all going to be aggregated to give us the letter score at the top. So this patient, if they came in with active chest pain, I'm getting an A score. Everything's looking good here. We may have some borderline single vessel disease, but I'm not seeing much globally. So I'm not quite as high on my urgency radar to get this person to a cardiologist. So then the part 2. This to me is really where the rubber meets the road. Once I know we're okay or we're not okay, now it's where do I look to help the patient? How many of you have ever had cardiac symptoms? Maybe you've gone to the ER or urgent care or to a doctor, heart palpitations, chest pain, discomfort, pressure, heavy beating. How many of you have gone in to be seen and have not gotten a specific answer of what the problem is? Raise your hand, drop a note. A few of you have. Okay. Cardiology is really, really good if they have a specific disease, if they know that the left anterior descending artery at the bifurcation has a 90% obstruction, they know exactly what to do, exactly what to stent. The more specific the diagnosis, the more specific the treatment is usually going to be in the cardiology world. However, these vague symptoms are going to be at the opposite end of the spectrum, right? They're going to be a little bit more challenging to find out where do we go from here. So that weird palpitations, right? If the testing comes back negative with the EKG and maybe a stress test, where do you go? And one of the things I struggle with is where do you draw the line? Because testing can get expensive. So that's why I'm always having a dialogue with the patient. How bad is this bothering you? Because if it's really bothering you, then we need to pursue it and figure it out. And if it's not bothering you, if you know an echo is $1,000, is it bothering you that much or not that much? That helps me put things into perspective. And by the way, an echo, if you go to a hospital and bill your insurance, is $7,000. If you go to a different door and pay cash, it's like 500 to 1,000. So that gets into a whole nother issue we won't go through tonight. So part 2 of this test, again, where the rubber meets the road. So I'm looking for how can I alleviate the patient's symptoms? What do I think is causing it? So it breaks it down into, these are 2 different pages. So these are the numbers of the runs across here. So for each EKG strip, it's going to give me pluses and minuses for the categories. And I brought in the same one twice. So these are the same from left to right. But myocardial remodeling. So that tells me, is it acute or is it chronic? Decreased myocardial compliance. Is it a stiff heart? Is it a diastolic dysfunction? Increased myocardial compliance. Is it a systolic dysfunction? Decreased ejection fraction. Is the pump not working very well? Bradycardia is slow heart rate. Tachycardia is fast heart rate. Acute power failure. So I don't know of any other test in the world that can tell you mitochondrial dysfunction in a cardiac perspective. Asynchrony, localized asynchrony. The other one has things on it like left ventricular hypertrophy, pulmonary issues, rheumatic heart disease. So they're just some more categories that tell me, where do I look? Right heart, left heart. Is this an energy problem, an electricity problem? Is the patient at risk of arrhythmias? And gives me kind of in my mind, from a functional perspective, where am I going to focus? Because not everything in the heart needs a slammed beta blocker. Maybe we need to improve the mitochondria. Maybe we need to optimize the thyroid. There's a number of things. So this points us in other related directions. So again, this is the non-FDA approved section of this, so it's considered investigational, but it can tell me if there's ischemia, and it can help differentiate between those hard plaques and those soft plaques. Coronary artery dysfunction, so it can tell me about spasm and things like that. And then those functional imbalances, so the microvascular glycocalyx, the thyroid, MTHFR is a big one. Is this patient have hyperinsulin, hyperglycemia? There's a lot of things that can help us pull out and again direct our care. So, how does it help you? Again, it gives me a therapeutic target. So, I'm not just shooting blind, I'm looking specifically. And one of the analogies that I've used before is imagine you're at an art museum and there's a painting on the wall, a mural on the wall. So each specialist only has their flashlight. So the room is dark, so you can't see anything, and each specialist has a flashlight. So wherever they pointed at the wall is the diagnosis they're going to make. That is their perspective, right? So each specialist is going to point their light in a different direction at a different piece of the artwork. My goal as a functional doctor is to make my light as big as possible so that I don't eliminate possibilities with that narrow specialty lens. I'm trying to connect those dots and get the light as big as possible. So this tool is really going to help me do that from a cardiac perspective. It's also going to give me, it's going to complement the standard testing. And again, I have a great case that I'm going to show you. Again, how soon am I going to start medications? What further testing do I want? More targeted interventions. Where do I put things on the priority list? Sometimes patients will come in and we have 5, 6, 7 things on the list to work on. It'll help set those priorities for us so we know what to work through. So how does it compare to other heart testing? EKG, again, it's going to be a lot more comprehensive than an EKG. If you're going to roll up in the ER with chest pain, of course you're going to get an EKG. That's fast, it's simple, it's going to tell me heart attack or no heart attack, arrhythmia or no arrhythmia. But once that's done, if it doesn't give me information, where do I go from there? We have the coronary calcium score. We're going to talk about that a little bit next week. So that's going to be that high yield CT scan that's going to look at obstructions in the coronaries. Do I have a blockage? Do I have calcifications? My only problem with that is where do we go from there? Most doctors, cardiologists that order this are going to tell you to take a statin. What is the side effect of statins? Cause calcifications in the arteries. So it's this feed forward loop that no one's explained to me. How does that help me? We have echocardiograms. So we can do an ultrasound of the heart. We can look at the pump of the heart and the architecture and the valves, and we can see, is there an area that's not squeezing very well? Is it all not squeezing very well? Is there a valvular problem that's creating dilation in one side of the artery or stress on one side of the heart versus the other? So I'm a big fan of the echo. I used to order those all the time in the ICU. Actually had a really interesting case where we picked up a patient who had cardiogenic shock on top of septic shock. So totally different dynamics. We picked it up with an echo and we were able to treat the patient that needed 2 different things at the same time. A stress test. How many of you want to go run on a treadmill and do a stress test? Hopefully all of you, because that's what you're going to do with the max VO2 testing. You go take a stress test, that doesn't really give you that much information in my opinion either. It's just an EKG in motion. So it's making you run to get your heart rate up to see, do we change anything? We have the nuclear imaging or SPECT scans to see, if we use nuclear medicine, can we detect any cells that might be prone to ischemia with due to coronary disease as we increase the heart rate and put stress on the heart. And then at the end, again, we have that angiogram. So you have to have a cardiologist. They take you to the cath lab. And one of the big scandals is you have doctors who do just a diagnostic cath where they take you to their cardiac center, they bill you for a diagnostic cath, and then they say, oh, well, you need an intervention, so now you need to come back and have an intervention. They bill you for 2 caths versus having a doctor who can just do it all at once. Big problems with that in my world. So again, we need a test that can tell us more information if we've exhausted all of our options. We need something that's non-invasive, repeatable, more accessible, fast, and doesn't require a specialist because there's a lot of people out there with hearts that are having cardiac symptoms. So, yep, I just went over this. So again, the coronary calcium score, it is going to help extrapolate a little bit, but not a big fan of that in lieu of if all we have to offer people are statins, which we don't. So this is a case that I have, real life example. So this is a 45-year-old male who had been in the ER multiple times for chest pain and anxiety. So chest pain would happen, rapid breathing, hyperventilation, heart rate would increase. We'd get up to the 140s, with this crushing chest pain. So on multiple occasions, trips to the ER for that standard EKG, chest X-ray, troponin, a stress test in the past, in an old right bundle branch block. So definitely risk factors. Definitely had bad COVID. Definitely had some metabolic and body habitus risk factors for this patient. I did the MCG. It was a class A. I said, please stop going to the ER. It's not your heart. And for those of you who might have read the blog, this is my brother. So this was an excellent investment for us, because now when I'm sitting here and he calls me from 5 hours away, I can say, hey, I don't think it's your heart. Are you on any medications? Did you eat something bad? Are you having reflux? Let's try this. Let's try that. And there, we kind of have a de-escalated sense of urgency, which again, if you're having a symptom, you have anxiety, it starts to wind, can be a bad problem. So we were able to alleviate that with one test, and now things are better. So a lot of investigation has been done on this. As you can imagine, in the cardiac world, there are mountains of different datas. Again, a lot of them focus on statins and LDLs, which I think are a bit of hooey, but they've looked at this in urgent care and ER. And again, the high negative predictive value. So if we have a patient in the ER with chest pain and the score is 4 or less, it is almost impossible that this is a coronary event. However, if it's 12 or more, we're going to have immediate cardiac referral or talking about maybe going to a cath lab. So it really can help us risk stratify people and sort that out. And one of the things I put down here is kind of an excerpt of one of the papers that they looked at, hemodynamically relevant coronary stenosis in women. So women and men have heart attacks differently. So this is going to help us differentiate and pick these up in women who, again, didn't read the book and don't have the same symptoms as men when they're having a heart attack. So this is also one of the tests that we can use to monitor our care over time. So just like that brain gauge shows us 2 points and shows us how the patient changed over time, the same thing can happen with the MCG. If we pick up a lot of dysfunction and different points on with a patient, we can then start interventions and see how over time that affects the individual. And I'm thinking every 2 months to 4 months, we'd be repeating this until we get a normal. And it might be something that we incorporate once a year for screening in an asymptomatic patient. Again, when you have somebody coming in, it's not always very simple, right? It's very common that we would have a patient with high blood pressure and a thyroid issue. We're treating both. Those are going to have different implications on the EKG or the MCG. So this will kind of tell us, yep, you got the hypertensive side under control, but we still need to work on the thyroid side or the metabolic side of it. It just helps us, gives us different touch points to monitor progress over time. So advantages of functional testing in general, it's fast, non-invasive, and high sensitivity. So everything we've brought into our office has been widely studied and published. It is not in mainstream. Well, some of it is, but it's in mainstream in components. So the glycocheck, those folks were in the ICUs when COVID hit. They were already investigating people. So when we look at the glycocheck data, I think they have hundreds of publications on that. FibroScan, again, lots of publications on how that can help avoid liver biopsies and detect fatty liver and fibrotic liver. MCG is a little bit younger on the spectrum, but again, in the field of cardiology, the developer, very published, he's out there, brilliant mind in electrophysiology world. So it can give us clinical direction if a patient has symptoms that we can start to target and look at and help them resolve it, even if it's an indirect symptom. And again, just dynamic function, not just static information. So again, the reminders, that Google review, we really, really appreciate. Here's where you can follow us. Quarterly focus for this time is cardiovascular, so a lot coming up. Next Monday, we're going to talk about advanced lipid panels and cholesterol management. So if you're interested in that, make sure to join us. But with that, I will open it up and take questions. So anybody out there? I do see a couple questions, so we'll start. Last week we talked about red light therapy, and you should have gotten a replay email, but if you didn't, it's on our YouTube. So you should be good to go. YouTube channel, jamesclinic.com, and I can pull that up for you. If you have a small piece of steel in your left arm, you're not a candidate. You should be if for that. You can do this test with a pacemaker as well. It's a cardiac test. So, yes, you can do it. We just don't want any outside metals involved. So, that's actually a really good question. You can do it. While you're gathering any last questions, I'm going to go to our YouTube channel and just show you. We have so many resources for patients, and we're really working on communicating all of those things to you to make sure you can take advantage of everything we have out there. All right. When I go to YouTube, and all of our searches might be a little bit different. So here's the red light therapy one from last time. So that's what you're looking for. But if you go to our James Clinic channel, so you're going to find that Mito Regen at the top where we talked about that. I just did a new series called Medical Briefings where I went over labs. So if you've had a lab review and you've left kind of thinking like that was a lot of information, you could actually go to one of these and you could do either Quest, LabCorp, or Genova and kind of have yours next to this and watch it through so you could pick up more information about your test. And then all of the ones that I remember to record go here. The red light therapy and some of the older ones going back. We also have some of the JC Elites, which are on pause right now due to military service. Linda, you had a question before. Did I miss it? Let's see. Linda, where'd you go? Linda, did you have a question?
I did, but mine was, can you hear me okay?
Yeah, we can hear you.
Mine was actually, I had raised my hand. I should have just did in Q&A, meaning to ask you the terrain one you had. I've never seen that one out there. I don't know that I see that one out there, or is that the older one? I saw the red light, but the week before, I didn't see that one posted.
I think I forgot to hit record.
Oh, never mind.
Sometimes I forget. I get so busy of like
Never
running.
mind. I loved that one. And I don't have anyone I know, but I just thought the information was so good.
Let me look back and see. Actually, I think I did hot yoga after that and thought I was going to die. So it might have been that too, but let me go back and look because I might have just missed one.
All right.
Yeah.
Sorry.
No, that's
I,
good.
I should have just sent you the
Nope, you're perfect.
okay.
And then Michael, did you have a question? Michael Loebner? You're muted if you're talking, but I clicked your microphone. If you had a question. Okay, it does not look like it. Oh.
No, and it's Karen.
Oh, hi Karen. Hey,
Hi?
I sent you your own invite, so you should have had it.
Nope, didn't get it, not in spam.
Oh, geez. Okay. Well, we'll just keep registering you until it comes through.
Okay,
All right.
thank you.
Yep, you're welcome. Okay, a past cardiologist I went to advised me to take a calcium score test. You mentioned it tonight. Can you go over the benefits and is it advisable? So it may be advisable. Again, I have people who come into my office just with a high coronary score, and I'm looking at things like, do we have insulin resistance? What are your lipids doing? I'm not jumping to a statin. Yes, you can get them, and you're welcome to bring those results to us, and we'll kind of risk stratify. But when you plug in there's something called the Mayo Statin Decision Aid. I'm actually going to pull that up because we've got a little time here. So I love it when the system has its own risk scoring because then we get to use that. So any of you can go to this website. It's a public website. So let's get started and you can actually plug in your own information. Do you have a history of heart attack or stroke? Let's say no. Let's do an age of 52. Let's do a male. Let's do a white male who is a non-smoker. Let's do diabetic. And let's just do diabetic. And the systolic blood pressure, let's say, was 135. The HDL, so the good cholesterol, let's keep it a little low at 34. And the total cholesterol, let's make it a little high at 234. And no statins. We're not on a statin right now. So our current risk of heart attack based on this is that 15 people will have a heart attack in the next 10 years. So about 1.5% per year. So now we can select an intervention. So this is again a 52-year-old diabetic, slightly high cholesterol. That's all we know. So we're going to go to the intervention. So we can collect the intervention. So let's do a standard dose of statin. So if we do a standard dose statin, 4 of those 15 will be saved from taking a heart attack. So then my question is, that sounds pretty good. Do you want to take a medication for 10 years for a 4% chance that you will get benefit? It's a real question, right? Statins are not free meds. They're not without side effects. So now we'll go back to the intervention. We'll do a high dose statin and we get 6 people who are saved. So you can plug your actual numbers in and see where it falls. We can do this in the office while we're going over your labs. If that's a concern that you have, we can actually check that out and put that right in your chart. What is your risk? I took a coronary calcium score, is very low, and after that they then labeled me as having coronary disease. I took Lipitor and ended up with a frozen shoulder. Yeah, so if you had anything on the calcium score, so we need to think about how the system of medicine bills. The system of medicine has things called CPT codes that are supported by diagnosis codes, ICD-10 codes. So it's oligemic and it feeds into the AMA. They own these codes. This is how they stay rich and powerful. So the more ICD-10 codes they can list in your chart, the more money they're going to make off of you. So anything that that can be done to add diagnosis to your chart will help them bill. Now, if you're wanting insurance to pay for something for you, that's nice. If you want to get health insurance and they put a bunch of diagnoses in your chart of things you don't have, that's a problem. What happened in the Monday morning webinars? Those are happening. So I'm not sure. Thank you for being here.